objectives of this talk is one, to highlight the importance of mineral bone complications in CKD, define the role of bone imaging and bone biopsy. I'm pretty sure they don't do bone biopsy here in Winnipeg. And finally, to review evidence on prevention and treatment of bone metabolism abnormalities, and of course, vascular calcification, because when you talk about bone disease, it's tightly associated with vascular calcification. And if we change treatment, if we start the treatment for bone disease, automatically it will affect the vascular tree and vascular calcification. So this is, I'd like to start with the case. So this is a typical case that you can see the dialysis unit. And as a dietitian or pharmacist, I'm pretty sure you've seen that kind of case. So this is a 71-year-old woman on hemodialysis with diabetes, hypertension, etc., with a recent hip fracture. So you have the lab parameters here, PTH between 300 and 400. I don't know if you have the same unit here in Winnipeg. Calcium a little bit low, high phosphate level, vitamin D 40 nanomole per liter, so a little bit low as well, and the same for bicarbonate. So we see that kind of patients very often, and the question is, what do we do to prevent the risk of fracture in that particular patient? And in order to answer that, we need to know what is the type of bone disease the patient has. So I have a few options for you. So first thing, you will think that this patient has a mineralization defect. You could say that because maybe the calcium, the vitamin D, bicarbonate are a little bit low, so maybe that are risk factors for bone mineralization defect. B, maybe she has an diabetic bone disease because she's diabetic. We know that diabetic patients are at risk to develop a diabetic bone disease. Maybe she has hyperparathyroidism bone disease, even if PTH is not that high. A mixed osteodystrophy, so a mix of A and C. Osteoporosis, does she have osteoporosis? Maybe. Or finally, it's very difficult to know the type of bone disease the patient has. That may be the right answer now. So maybe we don't know about the type of bone disease. If we don't know about the type of bone disease, then we can't intervene, we can propose a treatment for that particular patient. So think about that. I'm gonna come back a little bit later on this case on the second part of my presentation. So this is I would say the classical pathophysiology of renal osteodystrophy. So what you know and I know is that because of high phosphate level, because of the low kidney function, phosphate of course accumulates. There is a low calcitriol because the kidneys are not activating 125 hydroxyvitamin D. So you develop hypocalcemia, you develop hyperphosphatemia, and hypocalcemia and hyperphosphatemia all contribute to the elevation of PTH, parathyroid hormone. And if you're not treating this elevation of PTH, then you develop secondary hyperparathyroidism bone disease. So here in the gray compartment is the bone. So if you don't treat high PTH level, sustained high PTH level, then you have a direct effect on the bone. It increases bone formation, bone resorption, but in favor of bone resorption. So you will lose bone eventually. And of course, something that we don't talk very much is metabolic acidosis. Metabolic acidosis is a high risk factor for developing what we call osteomalacia. What is osteomalacia? Is a mineralization defect. So you don't incorporate calcium, you don't incorporate phosphate into the bone. So you have a low mineralization, and then you're prone to fracture. If we treat, sometimes we overtreat hyperthyroidism bone disease, and if we suppress a little bit too much PTH, then you can have what we call a low or dynamic bone disease. So you have no formation and no bone resorption. And this is very bad because the bone doesn't have the possibility to repair. So it's prone, again, to fracture. Okay? And sometimes because we overtreat with calcitriol, we overtreat with calcium. Some of the people without calcium treatment, without calcitriol, do develop a dynamic bone disease, and we see often in diabetic patients. And maybe one of the factors that we know for the last few years, some proteins we call maybe new players in the pathophysiology of renal osteodystrophy. Sclerostin, maybe you've heard about it. Sclerostin, DKK1, frizzle-related. These are some new players, new proteins, that their roles are to inhibit bone formation. So maybe they're highly involved in the development of what we call low bone turnover or dynamic bone disease. So one of my
Excuse me, sorry to interrupt you, Dr. Mac-Way. This is a group of nurses, and we're listening to you from St. Boniface Hospital, and it looks like you're referring to a screen, but we can't see that screen. Is there any way that you can make that accessible?
Of course, we're gonna fix that.
Well, you're watching your face.
I'm actually on the phone with them. That's what I'm actually calling about.
Okay.
They are on the phone. They're having trouble. So I am working with them to get that switched so that the slides will be showing.
Okay.
Yeah. No, that's okay. I'm on hold with them. They're hoping to get it fixed.
Okay.
All right, thank you.
So it's gonna be fixed in 2 minutes. Do I continue? I continue. Okay. So sorry about that. So why is that so important to control all of this? Because as you know, bone abnormalities lead to bone fracture, and we know in CKD patients the risk of fracture is higher as compared to non-CKD patients. And the risk of mortality after fracture is higher, 2 to 8 times higher in CKD population as compared to non-CKD population. And I already mentioned that there is a tight relationship between bone and vascular calcifications. And of course, if you have bone abnormalities, you have a higher risk of having vascular calcification as well. So if we want to understand. Do you see it?
Yes, thank you very much. Thanks.
So this syndrome that we call CKD-MBD for chronic kidney disease, mineral bone disorder. So this includes the lab abnormalities, of course, of calcium, phosphate, vitamin D, for example, but also bone abnormalities and vascular calcification. So when we talk about bone disease, as I said, we ultimately talk about vascular calcification as well. So it's very difficult for us as clinicians to know exactly what to do when we face a patient with bone abnormalities because of this. Because we have a lot of possibilities of bone disease in the CKD patient, advanced CKD patients or diabetes patients. So if we follow the guidelines from the KDIGO, we need to look at 3 parameters: the bone turnover, the bone mineralization, and the bone mass in order to predict what's going on. So, and you have, of course, the bone turnover could be normal, but could be low, could be high, as I said before. You could have a normal mineralization, but could have an abnormal mineralization. That's the osteomalacia. And of course, you could have a low bone mass, normal bone mass, or high bone mass. And the majority of CKD patients will have a low bone mass. Over 80% of CKD patients will have a low bone mass if you assess the bone mass with the DEXA, for example, or the DEXA. And of course, they have osteoporosis as well. By definition, osteoporosis is a high risk of fracture, defined by lower than minus 2.5 on DEXA. So if you just take CKD patients, you have a DEXA about BMD of less than minus 2.5, then you can say that this patient has osteoporosis. But the mechanisms of development of this osteoporosis is completely different from the standard osteoporosis, for example, we see in phospholipid osteoporosis. And the treatments, of course, because of that, depending on the diagnosis, the treatment could completely be different from patient to another patient. So how do we do to diagnose the type of bone disease? So for the bone turnover, what we use is bone markers. We use bone markers in our daily practice. And for mineralization and bone volume, we use diagnostic imaging. So what do we use? We use PTH and alkaline phosphatase. And I do think you use the same thing here. Do you have bone alkaline phosphatase here? Yes? Okay. So if you have bone alkaline phosphatase, not more specific to the bone, so it's not every centers that have the possibility to use bone alkaline phosphatase. So why do we use those markers? Because when we correlate these markers to what we call the gold standard of course, is still bone biopsies. So when we correlate, we know that correlation is pretty good between PTH, for example, and alkaline phosphatase. Here's bone alkaline phosphatase to the bone formation rate on bone biopsy. This is the gold standard for the level of bone turnover. So that's why we use PTH and alkaline phosphatase in order to predict the level of bone turnover. We know that it's not perfect. So there are other bone markers that we can use. For the bone formation, we have osteocalcin, and we have P1 and P. Osteocalcin is not very available. I use a few times P1 and P. It's not very, people in osteoporosis that take care of osteoporosis patients use a lot P1 and P. Okay? And it's not affected by chronic disease. So if you have the possibility to use P1 and P, it's a good bone formation marker. The same here for TRAP. TRAP is a specific enzyme from the osteoclast, so the cells that are responsible for the bone resorption. So and there are a few studies that correlated TRAP with the level of bone resorption on bone biopsy. Unfortunately, it's not very available for clinical use. It's available for research mainly. And you have CTX, MTX. CTX, MTX, unfortunately, accumulates in chronic kidney disease, so we can't use fraternized CKD 4 and 5 in dialysis patients. So now we use PTH and alkaline phosphatase because it's the best we have. It's easily available, but it's not perfect because this is a study that has been done a few years ago when they've looked on the bone biopsies parameters. So this is HHP is high turnover bone disease, low turnover bone disease, a normal level of bone turnover. And as you can see here, if you have a low PTH below 150, the majority of the patients have low turnover bone disease, the equivalent of anatomic bone disease. But if you have a patient between 150 and 300, you still have almost 15% of the patients with low bone turnover disease. And even if you have a PTH over 300, again, 50% of your patients will have low bone turnover disease. So we know that PTH is not perfect. But as I said, is the easily available and is the most used. bone markers we use now. It's not, by definition, it's not a bone marker because PTH is not secreted by the osteoclast or the osteoblast. PTH is the protein, the molecule that causes the disease. So it's not the bone marker, but we still use PTH. Do you use bone mineral density here in Winnipeg?
We do bone density.
You do bone density?
Whether we use it, say, in dialysis patients.
Okay.
Like transplant.
In transplant. Okay. So you remember in 2009, the KDIGO guideline, they didn't recommend to use bone density. So it changed. This year we have the new KDIGO guidelines. One thing you have to make sure is that bone mineral density is not only the bone mass. You have the bone mass and you have the bone mineralization. And I'm going to illustrate you with just a figure. Let's say you have a normal bone here. So a normal bone is composed of a mineralized bone, let's say here in green, and always a small amount of non-mineralized bone in red here. So if you, for example, you do bone mineral density by DEXA in this patient, you'll have, for example, 1.2 gram per centimeter square of bone mineral density. If you have osteoporosis, by definition, osteoporosis, you have a low bone mass. You lose bone because you have high resorption. So if you lose the half of your bone, then you have the half of your bone mineral density. If you have osteomalacia, so osteomalacia, you have a normal bone mass, but you have the half of your bone that is not mineralized. So you'll have the half of your bone mineral density. If you have in a dynamic bone disease, by definition, you don't form bone. You have a low bone, very low bone mass. But because of the very low bone mass, you have what we call a higher process of secondary mineralization. So you could have exactly the same amount of bone mineral density, and the same for secondary hyperparathyroidism bone disease. You have higher deposition of bone, but because of the high bone turnover, you don't have time to mineralize the bone. So you could have exactly the same amount of bone mineral density. So if you do a bone mineral density in CKD, advanced CKD patients or dialysis patients, you know that probably this patient has a higher risk of fracture. The bone is abnormal. But what is the cause of the abnormalities, you don't know with the bone mineral density. So does BMD predict fracture? So since 2009, there have been a few studies, prospective studies, that indeed show that bone mineral density does predict fracture risk in CKD patients. One of these studies here was published a few years ago, a prospective study of more than 2,700 patients, mid-age old patients, 73, in CKD 3 and 5, and they did bone mineral density at baseline and followed the patients for 9 years, and here are the results. And of course, in non-CKD patients, you see that when you have osteoporosis, so lower than minus 2.5 of BMD, our risk of fracture is higher as compared to non-osteoporosis patients. That's normal. That's the test we use for osteoporosis. And the same for CKD population. And if you look, if in CKD population with or without osteoporosis, of course your risk of fracture here is higher if you have CKD and osteoporosis as compared to the first line non-CKD and non-osteoporosis patient. Okay, so now because of this study and some other studies, it's recommended again from the last KDIGO that you use BMD to assess the fracture risk in CKD population. Okay. The problem now is that if you do a BMD and you know that the particular patient has a high risk of fracture, what will you do next? That's the big question. I'm talking to you about this machine. This machine is what we call a high resolution QCD. It's available. Some centers have this machine, and it has the particularity to assess both what we call the trabecular compartment and the cortical compartment. So the bone, it's always composed of two compartments. You have the cortical compartment outside the bone, and inside the bone, the trabecular compartment. And a few studies now have been published and saying that, showing that the cortical compartment, in addition to the trabecular compartment, are highly disorganized in CKD population. And probably that the cortical compartment contribute more to the bone strength than the trabecular compartment. And one of the examples of that published a little bit a few years ago by Nicholas in pre-dialysis patients. You can see here the bone of the patients with no CKD. CKD without fracture, so you can see already thinning loss of cortical bone. And in CKD with fracture, you have almost a disappearance of the cortical bone. So this is very important. When you do a bone mineral density assessment with DEXA, it's 2D. So you don't have the capability to discriminate between the trabecular bone and the cortical bone. But you have this possibility with this kind of machine. But unfortunately, it's not available everywhere. So even in dialysis patients, you can see here that the bone that are the most affected by CKD are the bones that have a higher amount of cortical bone. So the radius here, for example, and the tibia bone. Okay. So we have a lot of studies looking for the association between microarchitecture parameters with those kind of machines and prediction of bone fracture. And of course, we do all these parameters, trabecular bone, compartment, cortical bone, do is that we don't have enough clinical studies now, and it's not available for clinical use. And the third thing, we don't have the evaluation of bone turnover. So you have the microarchitecture. You can say that, for example, that the cortical bone, the thickness of the cortical bone is low. The thickness of the trabecular bone is low, but you can't say anything about the level of bone turnover. You say, do the patient have a high bone turnover, high formation rate, high resorption rate, low formation rate? We don't know about this without having the level of bone turnover. So what do we do as a nephrologist? So we want, of course, our approach first is trying to lower the phosphate level. So we use diet restriction. We use phosphate binders, calcium and non-calcium phosphate binders. And we want to lower, of course, FGF23. FGF23 is one of the hormone that is highly involved in controlling phosphate level, and FGF23 is highly associated with vascular complications. So we want to lower FGF23 by lowering phosphate level. We want to normalize calcium levels, but not too much. We don't want to give, of course, too much calcium because of vascular calcification. We want to lower PTH levels, but not too much. Again, so we don't want to induce dynamic bone disease. And we want to correct acidosis. It's very important for bone mineralization. So when I look, when I have patients with CKD-MBD who had fracture or not, I think it's very important I look at all of these parameters and make sure that all of these parameters are optimal. So, as I said, if we want to treat the bone defects, we have to think about vessels because of this, because vascular calcification or calciphylaxis. Do you see a lot of calciphylaxis here?
What's your definition of what?
You have a few calculations per year? Yeah? Okay. In the province of Quebec, it's pretty rare. We had around 10 for the last 12 years. So it's
Ours is higher.
so you have a lot, maybe in Toronto you have a lot of calculations as well. So it has, I'm pretty sure it has something to do with the calcium. We give a lot of calcium. We used to give a lot of calcium before, and we restricted a lot the amount of calcium we give to patients, of course, because of vascular calcifications. And one of the well documented now that one of the factors that that is associated with vascular calcification, of course, the age, the time you spend on dialysis, but of course the amount of calcium you give to the patient. Okay, so and the more vascular calcification you have, the higher your risk of mortalities. So, as I said, in the province of Quebec, we restricted a lot the amount of calcium we give to patients, and the guidelines changed. I'm gonna show the guidelines for the last guideline this year, saying that we should restrict calcium for probably every patient sometimes on CKD now, and not only restricted to some patients that have a high risk of calcification. What about phosphate binders in pre-dialysis patients? So this study was done by Jeffrey Block a few years ago, and the rationale was that if we maybe before the elevation of phosphate level, we could treat with phosphate binders, and then we'll prevent the elevation of PTH level and FGF. So he did a randomized controlled trial study, placebo. So these patients were had GFR between 20 and 25, no hyperphosphatemia. So put on placebo or phosphate binders, calcium, sibulamer, or lanthanum. So first question, there was no effect on the level of PTH and no effect on the level of FGF. But they realized that there were more calcification and the active treatment. So they put together all the three treatments on the binders, calcium, sibulamer, and lanthanum. They put together as the active group, and they've seen more calcification, coronary calcification, abdominal calcification in this group. That was mainly driven by the calcium supplement as compared to the sibulamer and the lanthanum. Here's the placebo. The same for the coronary calcification, the same for the abdominal calcification. So because of this study, as I said, it changed the last guidelines. I don't know if you had the chance to look at these guidelines, but for calcification, for example, so it's now recommended to restrict for all CKD patients. In 2009, it was recommended to restrict in patients with high risk of developing hypocalcemia, for example, or diamond bone disease, or sustained low PTH level. But now, from the last guidelines, it was recommended to calcium for all CKD patients because of this study, the last studies I've shown you, and other studies. So if I come back to the case, so what do you think this patient has? You need to answer one. Pick an answer. So now my answer will be F. Okay? And if you send these patients to, let's say, a rheumatologist, because he is the specialist, the bone specialist. So if you send this patient to a rheumatologist, what would be the conclusion? So the rheumatologist will tell you that this is a complicated case of osteoporosis. That this patient has definitely a high risk of fracture and fracture, with high risk of fall. That's the case for the majority of our CKD patients, dialysis patients. And he will ask the nephrologist if he can give treatments that he gives to osteoporosis patients. For example, bisphosphonates. Can we give bisphosphonates to these patients? And we give denosumab to these patients. Maybe teriparatide. We give a lot of teriparatide. Teriparatide is PTH. Alternative PTH, and they give teriparatide to osteoporosis patients if bisphosphonate is not working. For example, is not doing well. Or maybe antisclerostin. Do you have antisclerostin? It's not available yet, but it's in phase 3 studies for osteoporosis, and maybe in a few years we'll have antisclerostin available for osteoporosis patients. So a lot of rheumatologists, a lot of endocrinologists call me and ask me to try those medications for our patients. So what about bisphosphonate? Can we use bisphosphonate in CKD? So there have been a few studies, a lot of studies, but there have been meta-analysis, systematic review of bisphosphonate for studies about bisphosphonates and for osteoporosis. And then they retrospectively looked at the level of creatinine current, and then they conclude that yes, bisphosphonate can be used for CKD as well, because it reduces fracture until a GFR as low as 15 to 20 beats per minute. So we have to be careful about these studies because there are no studies now, randomized studies to look if bisphosphonate is effective in treating high prevent fracture risk in CKD population. So all of these fractures have been conducted in osteoporosis, in non-CKD. If you have CKD, you're excluded. If you have calcium or phosphate abnormalities, you're excluded. If you have high PTH, low vitamin D, metabolic acidosis, you're excluded from these studies. So even if they used the level of GFR and they retrospectively look at the studies, these are not CKD patients. Okay, so I think we have to be careful about the use of the generalized use of bisphosphonates in CKD patients. What about denosumab? So denosumab, called Prolia, pharmacists know about this medication. So Prolia is an anti-right ligand, so it decreases bone formation. Okay, it's given two times a year, once every 6 months, and it's well given to osteoporosis patients. Okay? It's more potent than bisphosphonates and does not accumulate in CKD. But then again, when you look at the studies that have been done, if you look on patients between 15 and 30 units per minute, there were only 60 patients. Okay? So we don't have any studies now about denosumab in these patients, in CKD, advanced CKD patients. You have over 60, okay, can give denosumab. You're between 30 and 60, and you don't have abnormalities, mineral abnormalities. You have normal calcium, phosphate, PTH, no vitamin D deficiency. I think it's okay to give bisphosphonate and denosumab in these patients. And you have to be careful when you have advanced CKD bone disease, because we've seen a lot of hypocalcemia, severe hypocalcemia in patients that have been treated with denosumab. And hypocalcemia, we just said 3 weeks ago, a patient with tetany, with severe hypocalcemia, total calcemia of 1.2, I think. And we didn't know, but her family doctor just prescribed her denosumab for her osteoporosis condition, and the patient was on PD. We weren't aware about this medication, and we just see she developed tetany, and she was admitted in emergency room and then ICU with a lot of calcium replacement in order to replete the calcium level. And denosumab, because we give it 2 times a year, so once you give the denosumab, you have the effect for 8 months, 2 months. So you have to be careful about that. I've given denosumab in many patients on dialysis. You have to make sure that the calcium level is okay. You have to make sure that vitamin D is repleted, and you have to make sure that the patient doesn't have bone mineralization defect or a diamond bone disease. Okay. Teriparatide, I've used teriparatide 2 times on my patients. I think there is a rationale to use teriparatide in patients with a dynamic bone disease or low bone turnover disease. And again, with the same principles as bisphosphonate and denosumab, teriparatide has been, Paul Miller has looked at the retrospectively on the osteoporosis studies and concluded that until 30 meals per minute, teriparatide can be safely given to patients until 30 meals per minute. And again, the same precaution. I think we have to make sure that this patient don't have mineral abnormalities. If they have mineral abnormalities, I think we're in another situation, another condition, and you have to be careful about this. And sclerostin, sclerostin, as I mentioned, is a protein that inhibits bone formation. So anti-sclerostin inhibits the inhibitor. So if you inhibit the inhibitor of bone formation, then you increase bone formation. Okay. So it acts differently as compared to PTH, teriparatide, but the effect is the same. So you increase bone formation. So what about the last KD guidelines? So the last KD guidelines, in patient with CKD stages 3 to 5, it's reasonable to perform a bone biopsy if knowledge of the type of renal storage will impact treatment procedures. That's again the question. What is your treatment? If you don't have bone biopsy, what is your treatment of, for example, the typical case of what would be your treatment? If you don't have any treatment, you don't expect to treat the patient, or you don't have the BMD, you don't have to do bone biopsy. But if you want to treat the patient, it is better to have BMD, and it's better to have the bone biopsies in order to know what exactly type of bone disease the patient has, and then it will guide the treatment you give to the patient. So these are my recommendations. That's what I do now to prevent fracture in my patients. So I do make sure that the patient has, if the patient has a high turnover bone disease, if for example the PTH is pretty high, for any reason you don't have, and the patient has high risk of fracture because of you have the BMD results, or because the patient fractured already, I think you can use an anti-receptive bisphosphonate or denosumab, for example. If, as I said, if you use denosumab, you have to check for calcium and vitamin D. Teriparatide can be used if you have an endemic bone disease or low turnover bone disease. But in order to diagnose the type of bone disease, you need to have a bone biopsy. If you don't have bone biopsy, you don't have the possibility to diagnose the type of bone disease, and then you don't have the possibility to treat the patient. Is it time to utilize bone biopsy? So this is a paper from the European working group, the CKD-MBD working group. It was released a little bit earlier in NTT
I think in June. And one of the things they want to do is that they want to revitalize bone biopsy again. So they want to revitalize bone biopsy as a clinical useful tool in daily practice. We're far from there. Bone biopsy should regain prominent place in daily practice to help tell CKD-MBD therapy and develop patients, etc. So bone biopsies are not done. Pretty sure we don't do bone biopsies here in Winnipeg. It's rarely done across Canada. It's rarely done in RUC, so they want to form the nephrologists from clinicians to do bone biopsies. There's a lot of barriers to bone biopsies. So what are the barriers to bone biopsies? So people would say it's invasive, it's painful. I think the majority of people, clinicians, they don't know how to do bone biopsies. They've never seen bone biopsy before, you don't know how to do it. And there are only a few people that are able to interpret the bone biopsies. So I do the interpretation. We're two in Professor Quebec that do the interpretation. Then there's another person, endocrinologist in Montreal, who does the interpretation reports. But I think the two main barriers, I think, is 1 and 2. So let's see if the invasiveness and the pain is really a barrier to bone biopsy. So here's the complications rate of bone biopsy. Sort of done in more than 9,000 bone biopsies, patients who had bone biopsies. So what we see some bleeding, hematoma, in 21 patients, over 9,000 patients. Pain that lasts more than 7 days, 17 patients. So 0.19%. Neuropathy, 0.12%. So in total, there were complications in 57 patients over 9,000. That's not a lot. If we compare to kidney biopsy, we do a lot of kidney biopsy. We do kidney biopsy every day in nephrology. And this is an example of publication that was made by one of our colleagues in Montreal. The complication rate of kidney biopsy, hematoma, 15%. Pain that lasts more than 7 days, that needed radiologic assessment, 7%. That's a lot compared to biopsy. So bone biopsies is a very, very, very low complications procedure. And I don't know, a lot of people think that it leads to a lot of complications, even if the majority of people never performed bone biopsies before. So people are stuck with this assumption that the complications rate is actually very low. So the other thing, so this is, I would say, the majority of the people who do bone biopsy, we do it on the classical way, so blind technique. I learned in France to do the blind technique. So it's usually performed by the clinicians, the nephrologist, the endocrinologist, the rheumatologist. You have the site, so you use the crest, the anterior crest on local anesthesia, and then you do the bone biopsies. And sometimes you remove the needle and you don't have enough bone. This is very bad because you have to do the biopsy again. So because some patients, some patients are more difficult than other patients, and so you have to be careful. And I was learned that from France that it's the bone specimen is very, very, very. You have to be careful. You take the bone specimen, you have it. You keep all the bone specimen for bone is not bone. So I think trying to convince the clinicians to do bone biopsies again it won't be successful. I don't think the nephrologist will do it again, the clinician will do it again. So what we do now in Quebec is that I approach the radiologist to do the biopsies as we do the kidney biopsies, as we install catheter, for example. I know here that the nephrologists do the installation for a PD catheter, for example. So if you have a nephrologist that do a lot of interventions, then maybe that practical nephrologist would be interested in doing biopsies. But other than that, the majority of nephrologists are not interested in doing that. So we do it with the radiologist under fluoroscopy. Then we see exactly where we're going. We have always a perfect specimen, and probably with even less complications of the procedure. Can be performed everywhere. And of course, the goal is to allow an increased access to foreign biopsies. So that's how we do it on the iliac crest. So here is the right iliac crest. So under fluoroscopy, you can see exactly where we're going to go. So here's the iliac crest, the outer cortical bone, and the inner cortical bone. And then give local anesthesia. And then we go for the biopsy. And then we go through the outer cortical bone, inner cortical bone, to have a specimen, always a perfect specimen. And we've done a lot of technique to cut the specimen in three, then we keep the specimen for future use, because we started now a registry. So this is, of course, for clinical use. It has the possibility to change our approach of CKD-MBD, our approach to patients with the risk of fracture. And of course, we want to run a study, conduct a study, to see what is the prevalence of dynamic bone disease now in 2007. The last bone biopsy studies have been done more than 50 years ago. So we don't have bone biopsy studies per se. So I think we need to know the prevalence of the different types of bone disease. What is the effects of the current treatment of bone disease on bone turnover and bone microarchitecture, and then to allow translational mechanism studies. That's what we're doing now. So how can we improve research studies on CKD-related bone disease? I think we still need to do research on the mechanism of CKD-MBD. So when we talk about CKD-MBD, we talk about bone and vessels. So I'm doing research on animals models of CKD, and we need to continue to do research on animals because we need to look at the mechanisms. We need clinical studies with accessible imaging techniques. Now we have BMD. I think it is probably time to see whether the BMD results in our CKD patients, how it is correlated with bone biopsies, for example, and the level of bone turnover on bone biopsies. And conduct translational studies in bone biopsies. So I'm going to conclude on this. I think we have to take care of the bone and the vessels. And when we look on the patient with mineral abnormalities, calcium, phosphate, vitamin D, PPH, FGF33, if you have FGF33, metabolic acidosis, you will have BMD results because we tend to do more bone mineral density. Now, then you have to give an option of treatment for your patients. So you change PPH, you're changing the calcium, you're changing the phosphate, but now we don't have any idea of what is the effect of the changes we do to the bone. And the outcomes we want to prevent is the bone fracture and the vascular calcification. So I think doing bone biopsies, it's an old procedure, but I think we have to facilitate the use of bone biopsies, and one of the solutions to bone biopsies through the radiologists under immediate procedure. And then I think with that we have the results, we have the tool to treat our patients because we don't do anything for our patients who have bone fracture, for example, high risk fracture. So I want to thank, these are my collaborators, these are my students, research students. I'm happy and fortunate to have one of the rare multi-stomach technicians in Canada, who works with me, and all the organisms that give us funds to our research. So thank you.
So would you ever diagnose high turnover disease without bone biopsy? So say the example, the case even where she had a hip fracture. Let's say her PTH was much higher than like 800 or plus. And you do a bone mineral density. So in that person, would you feel confident? Yes, I'm going to call this high turnover without a biopsy. What?
I wouldn't do a biopsy
In that case.
patient. If you have a very high level of PTH, your positive predictive value of high bone turnover is pretty good. So if you have over 800 PTH, you have 92 to 94% probability to have.
And would you use 800 as your cutoff?
800.
You would use 800.
I use 800. The problem sometimes is, but it's a small percentage of the patients, they will have mixed osteodystrophy. So with the high bone turnover disease, they still have bone remineralization. But it's a small percentage of the patients. So I don't think bone biopsy should be done those patients because the majority have a high bone turnover disease.
And so if you have a patient that's refractive and has a high turnover bone disease and has chronic high PTH, then instead of using any of these therapies, is your practice then to refer them for parathyroidectomy? And then would you remove these therapies post-parathyroidectomy then?
Yeah.
And so that they would never be put back on, even though they will still have osteoporosis. Or
Exactly. So if you don't, so we have to lower PTH, medically or with surgery. So if you, there have been studies, if you do surgery, for example, you remove the glands, then the BMD increase after the surgery, and your risk of fracture decrease after the surgery. So definitely, in those patients with refractory hyperparathyroidism, we need to remove the glands.
are you putting people on Prolia that have normal to low PTH then?
With no PTH, I do bone biopsies. So before giving Prolia or bisphosphonates or terpathide, majority of my patients I do bone biopsies. And
I was going to ask, because Prolia, this has come up a few times, and whenever sort of the nephrologist and I are discussing it, with all these case reports of severe hypocalcemia, we've always said no to the doctor who's asking, whoever it be.
I do the same.
So is that still a reasonable approach? Because we do not have bone biopsy here. And we recently had a case of severe hypocalcemia.
So that's the problem now. That's the problem. Because those medications are not conjugated, we have conjugation of medications in advanced CKD patients, in dialysis patients. So if you decide to use Prolia, for example, bisphosphonate in dialysis patients, it's because you decided to treat this patient. So you need to know what you're doing. Because, for example, if you have a complication, you have severe hypocalcemia, you have tetany, and you have complications, then you have to explain to patients why you use that that department.
Right, like I feel like we're going in blind with
Exactly,
bone biopsy
exactly.
with these medicines. So would you say
Exactly.
even for bisphosphonates,
I
your
don't
patient
use
would have had a biopsy already?
Exactly.
They would have.
I'm not using anti-resorptive treatments in my advanced CKD patients without having that result.
Okay. And how would you dose the bisphosphonate?
I use the same dose. I use the same.
Regular
I don't
dose,
change.
don't
I don't change.
cut it back.
Yeah. Some people use once every 2 weeks, once a month. We don't have any studies, of course.
And you're just using oral
bisphosphonates.
Down to which stage of PBC? Like down to down to dialysis?
Dialysis, yeah.
Really?
Dialysis. So, for example, the patients with high PTH, okay, for any reasons we were not able to lower PTH, and you have thyroidectomy, medication you give is not effective, and sometimes if the patient has a high risk of fracture, then they give thyroid. Of course, you're not dealing the cause of the problem. You still have high PTH level, but at least you have a treatment and you stop it, not stop it, but you decrease blood is not properly the initial if you do it on a blind way, you don't have any data.
I'm interested that you just give like the normal dose orally.
Yep.
Just to, because what I've read in the past, the half-life in nephrectomized rats is like 10 years for those drugs, but you seem to be
When you use
less stressed about that than I am.
you have to stop. The bisphosphonate, when you give it once a week or once every 2 weeks, you know that